The enemy is never more unnerving than when he's invisible. The words of K.J. Parker are very much relevant to the situation we find ourselves today, being faced with the COVID-19 pandemic. Today I will be talking about the influenza pandemics in the Maltese Islands, and mainly their history and how they developed in the individual pandemics that occurred in the 20th century. Now, influenza is not COVID-19. It's caused by RNA myxoviruses, of which there are 3 types. Basically, it is type A that causes the pandemics that we are very familiar with in regards to influenza. The term was first applied as an acute viral respiratory disease in 1803, when it caused an epidemic in Britain. COVID-19 is caused by the coronavirus, and this is a large family of viruses that cause illness ranging from the common cold to even more severe disease. And what we have in COVID-19 is a novel coronavirus that causes a severe acute respiratory distress syndrome that has not been previously identified in humans. So it's a new mutated virus. We'll be talking about influenza. The influenza pandemics in Malta probably go back to very early times. In the summer of 1580, for instance, we know that there appears to have been what is presumed to be an influenza epidemic based on the symptomatology of this disease at the time. This spread from Asia Minor, mainly in Turkey, to Sicily, Malta, and North Africa. By August, it spread to mainland Italy and southern France. It left a very high death toll in its wake, especially in the very young and the elderly. We find another episode of potential influenza pandemic in the winter of 1682, and here we have a Gozitin apothecary, a pharmacist, who requested remuneration from the grandmaster for drugs applied to the sick poor during the epidemic. However, we do not know, the document does not tell us any further information about the duration, clinical features, or mortality of this epidemic. In the 18th century, again, in February 1730, we know that there was a catarrhal influenza with slight fever, which affected the whole population. And again, 3 years later, in March 77, we have a grave epidemic of influenza of catarrhs, headaches, and fevers, which affected the population. And this was probably part of the integral 1729-30 pandemic that probably started in Russia, spread to Europe and the Americas. This was associated with a very high infectivity rate, high morbidity, but comparatively low mortality rates. And the ones that died were mostly infants, the elderly, and those affected with respiratory conditions. And the pandemic flared again in 1732-33, starting in Russia and spreading to the remaining Europe, reaching southern Italy and Malta in the early spring. In January 1746, we have another outbreak which started among the fleet and spread to the civilian population, and there were many sudden deaths that occurred. This again might have been a local resurgence of another European influenza pandemic which started in January 1742 and affected Sicily in February 1743. We have more records from the 19th century. In 1829-32, there was another influenza pandemic starting in China in October 29. It reached Russia November 30, so a year later, Europe by February 31, and Sicily by December 31. Became dormant in 32, but again re-emerged in a pandemic form in 33, and in Sicily, this came about in November 33. The high infectivity, but low case fatality. There's no record of this in Malta. But we do have a record where the Maltese population was affected by influenza in 1836-37. Few people escaped the infection, and the cholera epidemic followed in the wake of this infection. The pandemic started in Australia in October 36, spread to reach Europe in December 1836, and then spread to South Italy, Sicily in May 37, and with Malta we got affected by June 37. This had a very high infectivity rate and a high mortality. The next epidemic we have is in November 1847, where a number of persons afloat and ashore, civilian or military, high or low, rich or poor, were affected with the disease. It subsided. It only lasted about a month. It subsided within a month. It had a high mortality, since it is recorded that the viaticum is constantly to be seen and the voice of the priest heard on his dismal mission to shive the dying. The pandemic had started in Russia in January 47 and spread throughout the Western and Southern Europe, reaching Malta in mid-October, again with a high infectivity and mortality. In 1864-65, again, the Maltese population was affected by an epidemic of fever, accompanied with profuse sweating, lassitude, headache, exanthema, and lumbar pains. It's not identified specifically as an influenza, and then a cholera epidemic again followed in the wake of this infection. In September 1873, again, we have an epidemic with typical manifestations of influenza. Cases were first noted in Senglia, but spread to Cospicua, Paola, Zaytun, and the surrounding villages. This again had high infectivity, but low mortality. Compulsory notification of infectious disease in Malta was only introduced in 1871, so any records before that time are not really have epidemiological value. And even then, in 1871, the original ordinance failed to include influenza in the list of notifiable infections. Influenza was only made notifiable on the 20th January 1890. And then since then we have detailed records of different influenza epidemics. So we have the Asiatic flu in 1890, this was what initiated the inclusion in the ordinance, and the Spanish flu, the famous Spanish flu of 1917 to 1922, the Asian flu of the late 1950s, Hong Kong flu of the late 1960s, and then the Russian influenza, which didn't really affect the Maltese islands in the late 1970s. And so in the 50s to 70s, we got more or less an epidemic, a worldwide epidemic every 10 years. This has been curtailed now with the development of vaccines and the vaccination programs. So to look at the various influenzas, if we look at the 1889-90 influenza pandemic, this pandemic started in Eastern Russia and spread quickly to Asia and Europe, and eventually to America, Africa, and the Australian continents. We got succeeding waves of this pandemic, which were more severe than the initial outbreak. And even after they passed, many countries continued to have local recurrent influenza epidemics in the subsequent years. The same happened in Malta. So we find Malta, we find resurgence of this epidemic influenza throughout the following decade. And the pandemic affected us, and it assumed very unusual proportions, and as I said, stimulated the Chief Government Medical Officer, Professor Salvatore Luigi Pisani, to include influenza as a notifiable disease for the first time. Well, looking at what happened with the statistics that are available, this influenza had a case fatality rate of about 4%. The subsequent epidemic again was similar, about 3.3%. And you can see that we got a very high rise in 1890, came down in January 1890, came down in February, and was more or less very low in March, and then again in 82, in January 82, we start seeing a rise that peaked in February. So there was this two-wave appearance. And the deaths in the first 2 weeks of January were 24. There were no deaths in December. The first wave peaked in the second 2 weeks of January with 859 cases and 39 deaths, and then the whole wave abated by the end of March. The resurgence again gave us 2017 cases with 66 deaths. And then in subsequent decades, we see a number of local epidemics occurring. So we have another epidemic in January, May of 1894 with 615 cases. In August 1895 with 552 cases and 13 deaths. And in February, June 1900 with 2,260 cases and 78 deaths. So the case fatality rate of the influenza at this time was between 2.4 to 4%. We come to the famous influenza pandemic, what was termed the Spanish flu, and this affected the whole population, which was at the time in the grips of a worldwide conflict, the World War I. This infection is estimated to have caused the loss of more than 20 million lives. So quite a devastating effect on human populations in general. There was massive movement of troops, and obviously these helped the spread of infection. And it is estimated that between 250 million individuals were affected by the infection. We don't know where this infection started, but the first real point of attack was in Spain, where some 8 million Spaniards fell ill during the beginning of the pandemic. So this is why it's termed the Spanish flu. It spread out, it's obviously struck the military bases where you have a lot of combatants together, and then country after country was affected. Well, the Maltese Islands during World War I served as the nurse of the Mediterranean. So there was a lot of movement. It was a place of internment for prisoners of war, a home from refugees. So there was quite a lot of international movement coming in and out of the island. And this helped introduce the infection and also helped to spread the infection elsewhere. Once the infection got underway, the chief government medical officer of the time, Dr. Arturo Creten, started off a number of precautionary measures. There were generally prophylactic measures to try to prevent. So he ordered the prevention of overcrowding in public places and also ensured that these localities were kept clean, aerated and disinfected. He reduced the visiting times in the various charitable institutions, including the elderly, and discontinued the pawning of clothes at the Monte di Pietà. One has to appreciate that at this time, the modes of contagion were not all that clear, but ideas were being developed of how infections were transferred. He closed down the government-run schools, increased visits to suspected dwellings by sanitary inspectors, and there was surveillance, so quarantine was reintroduced for arrivals from overseas, and their belongings were disinfected whenever necessary. On a more individual level, there was a public propaganda to emphasize how contagious the infection was and how it was transmitted, and the need to maintain personal and domestic cleanliness. There was simple isolation at home of early non-severe disease and forcible isolation for those that were severe. They were kept either in the home or in the infectious disease hospital, and their homes and property was disinfected. And all cases that occurred in the charitable institutions, prisons, ships were isolated at Manuel Island, on Manuel Island. And if you read through this, you will see that a lot of the measures then are the measures that we are taking today against the COVID pandemic. Well, in Malta, if we look at the Spanish flu in Malta, it appeared around June 1918. So around June 1918, we started seeing some cases, and it persisted until June 1919. So it took a whole year to disappear completely. Overall, it affected over 20,000 civilians, And so it gave us an incidence of about 9% of the population. And of these, we had 807 deaths. So that works out a case fatality rate of about 4%, which means that 4%, 4 out of every 100 persons who got infected died. The incidence was slightly higher in Gozo, so it was 108.2 per thousand population, than in Malta, which was 88.6. And in Gozo, again, the fatality rate was higher than that in Malta. We also know that about 6,000, just under 6,000 cases with 199 deaths affected personnel of the naval and military British service. These, unlike the Maltese population, had a lower case fatality rate. It was just under 2%. Then following that epidemic, one finds that there were low influenza rates between April 1920 and March 1921. So for a whole year, the rates were low. But then we see a smaller scale epidemic with over 5,500 cases during 1921-22. And then even subsequently, we get some local epidemics in 1929 and 1943. If we look at the 1918-1919 epidemic, you see these waves and the typical waves both during the epidemic period. And so we see that in the first attack in between June 1918 and June 1919, you see this two-wave pattern that goes up and down, and in 1 month, in October 1918, we got over 6,000 cases in that particular month. And then eventually, even on an annual level, we see this repeated outbursts of the epidemic on a local scale. So there are these multiple waves that one has to face when facing this type of viral disease. One has to keep in mind that at the time, vaccination was not available. Vaccination against influenza was not available. Moving on into the second part of the 20th century, in 1957-58, again, we got the Asian flu pandemic, and this affected Asia, Europe, North America, and the African continents. It also affected the Maltese population. We first saw it in August 1957. It was introduced by a crew of a ship docked in Malta, but then it peaked, declined, and again we got a second wave in November, tailing off in December. And this epidemic, local epidemic, gave just under 9,000 cases with 11 deaths. So at this stage, this was a very low case fatality rate, so only 0.13 per thousand. It was quite, the whole thing went quiet in 58, some cases in 59. In 58, we only had 39 cases. Again, resurgences in alternate years in 59 and 1960. So again, we see this epidemic decrease in cases, another epidemic decrease in cases, and keeps going down, fluctuating that way. We have to look at these epidemics and see a bit, get information about the age groups that were affected. It is interesting to see that in 1890, the ones that were affected badly and that died basically were the elderly, whereas in the Spanish flu influenza, it was more the young that were affected. So the first epidemic that really we have data about affected the elderly. The next wave, 30 years down the line, affected the young. And this is possible because the elderly had been immunized during the original wave and survived, and it was more the younger population that was susceptible to the infection. In the 1957, well, it's more, the elderly were more at risk, but the rates of death were very much less In 68, 69, we had the Hong Kong flu. And again, this influenced the Maltese islands later. It affected us in 1969, 1970, over that period, and during that period, we had just over 1,000 cases with 23 deaths. The case fatality was about 2.3. It is possible that we had more cases, but there might have been underreporting of cases during this period. In 77, 78, we had the world was affected by Russian flu, but we have no evidence of this really affecting the Maltese population, possibly because of lack of adequate registration or because it did not quite, we were still immunized from the previous wave of influenza, local influenza epidemics that we had. Now we're facing a different virus altogether, COVID-19, which is similar to a certain extent to influenza in its symptomatology and in the way it progresses. But obviously, as I said at the beginning, it is a completely different virus. And there's a bit of data that we have so far, where we've had the epidemic going on since the 7th of March locally. And the incidence to date is 0.94 per 1,000 population. We've not had, we have under 500 cases so far. Many of these are recovered. So, we're now on the downward trend of the first wave of this epidemic. And interestingly, if one works out 7-day averages, one sees that the first wave of cases that we had were cases brought from overseas, so they were travel related, but then eventually within that we got a second wave, which were the direct contacts to these, and then eventually we got the third wave that gave us the community, introduced the infection to the community, and that has now come down. But potentially, and most likely, it will rise again with the second wave. Once things abate, we will probably get the second wave. So, the history of, if we look at influenza epidemics, they emphasize the need of tackling the infectious disease dragon, if we want to call it that, our unseen enemy, onto fronts. And basically, these two fronts are prevention. So we need a good surveillance system with accurate registration. So we have the current legislation, and the Department of Health does this to a fine-tooth comb, trying to identify individuals and keeping very good records, which give us an idea of how the disease is behaving within the community. We have to introduce quarantine procedures for those that are infected and their contacts. We've also introduced quarantine procedures from blocking contact with overseas. So we've closed our borders as much as we possibly can. We avoid unnecessary mass meetings. So, this is the concept of social distancing and, avoiding crowds and an increased number of people which can transfer. COVID does not appear to be transmitted by animals, but some infections can be transmitted by animals, even birds. For instance, Nile fever, West Nile fever can be transmitted by birds. So if we do get an epidemic of this, then we need to make sure that there's no contact with the wild avian, with the birds that come over, so no hunting or trapping in those instances when it's linked to animal transference. And obviously, when it's available, we have to have vaccination protocols for high-risk individuals particularly, but also for the population. The other front is that of curing, so we need to plan for hospital space, especially ITU facilities, because these patients who get these infections, respiratory tract infections, will need ventilation. That's best managed in an intensive therapy unit. And we've heard a lot of plans and projects to increase ITU facilities in our healthcare service, we have to treat complications early and, if proven useful, the use of antiviral agents. Well, thank you, and I hope you've learned something of how to look at the COVID monster that is hitting us today.